So if you look up the promise of hormone replacement therapy, HRT for menopause, you're essentially sold this medical magic bullet, right?
Oh, absolutely.
Yeah, I mean, you're told it's the ultimate cure. It's going to fix the hot flushes, the crippling night sweats, and, that heavy brain fog that makes you forget why you even walked into a room.
Right. The marketing around it is it's very optimistic.
Exactly. But then you actually get the prescription, you start taking the hormones, and suddenly you feel incredibly bloated. Your breasts ache, you feel nauseous, and your mood just absolutely plummets.
Yeah. It feels entirely backwards for a lot of people.
Right. Because you take a treatment to fix your hormonal chaos, and the immediate result feels like, I don't know, like the cure is actively mimicking the disease.
It is a massive shock to the system. I mean, the body has been steadily starving of estrogen and progesterone for months or, even years during perimenopause.
It's literally depleted.
Exactly. You don't just introduce a sudden flood of those chemical messengers and expect the body to seamlessly flip a switch back to normal. You are forcing a complex, highly sensitive biological machine to wake up and, completely recalibrate its entire cellular environment.
And that biological recalibration is exactly our focus for today's deep dive.
Yeah.
We have pulled together a really fascinating stack of clinical guidelines, NHS data, and some great insights from specialist menopause clinics.
There's a lot of really grounded data to dig into here.
There really is. And our mission today is to map out the reality of starting HRT for you. We're looking at what the most common initial side effects actually are, the biological reasons why they happen, and probably most importantly, when they actually go away.
Because understanding the underlying mechanism is critical here. Knowing what is physically happening inside your cells, that's often the deciding factor between abandoning a treatment that could, profoundly improve your long-term health and successfully weathering the transition phase.
Let's start by defining what we are actually weathering then. The clinical sources group the most common early reactions into a very memorable category. They call it the 4 Bs.
Ah, yes, the 4 Bs.
Right, which stands for bleeding, breast tenderness, bloating, and the blues. And the data shows this isn't just like a rare occurrence for a few unlucky people.
Not at all. It's incredibly common.
Yeah, bloating affects roughly 23% of women starting HRT.
Yeah.
And for breast tenderness, there were clinical trials for a single capsule bioidentical HRT called Bijuve, and those showed about 10.4% of users reporting significant soreness.
And when you add in physical reactions like temporary headaches and nausea, it is a heavy list of grievances right out of the gate.
So what's the biology behind those specific physical symptoms? Because it sounds miserable.
Well, it essentially comes down to how tissues respond to sudden hydration after a prolonged drought.
Yeah.
Okay, estrogen is a hormone that actively promotes cellular growth and fluid retention. During perimenopause, as your natural estrogen levels drop, your tissues adapt to that dry spell.
They sort of shrink down.
Exactly. They shrink slightly, they hold less water. So when you swallow that first HRT pill or apply that first patch, you are introducing a sudden, massive wave of estrogen into a severely depleted system.
Oh, I see.
And the cells in your breast tissue and your digestive tract, they react by fiercely holding onto water. They gorge themselves, which causes the immediate swelling, the bloating, and that physical ache you mentioned.
So it's less like breaking in a new pair of stiff leather shoes and more like pouring a gallon of water onto a severely dehydrated houseplant.
That's a perfect analogy.
Right, because the soil can't absorb it all at once, so it just pools on the surface and makes a huge mess until the plant slowly adapts.
And that adaptation process is fascinating at a microscopic level. It involves a biological mechanism called downregulation.
Downregulation. Okay, how does that work?
Think of your cells as having thousands of tiny satellite dishes on their surface. And these dishes are specifically designed to catch passing estrogen molecules.
Right.
When estrogen levels are low during perimenopause, the cells build extra satellite dishes, desperately trying to catch any faint signal they can.
Because they're starving for it.
Exactly. Then, when you start HRT, suddenly there is a deafening roar of estrogen signals. To protect themselves from being overstimulated, the cells physically pull those satellite dishes inside their cell walls.
Wait, really? They physically dismantle them?
Yes. They dismantle the receptors to literally turn down the volume. And as they do this, the breast tenderness and bloating gradually subside.
Wow. Okay, but if the cells literally have to dismantle their own receptors to turn down the volume, how long does that biological renovation actually take? I mean, if you're bloated and nauseous, you want to know when the discomfort ends.
The clinical consensus, and this is across NHS guidelines and the British Menopause Society, is 3 months. or roughly 12 weeks.
3 months. That is a significant commitment when you are feeling miserable.
It is. But biologically, it takes about that long for complete cellular turnover in certain tissues and for those receptor levels to fully stabilize to the new hormonal baseline.
And that timeline becomes intensely relevant when we look at the first of those 4 Bs bleeding.
Hmm.
The data on unscheduled vaginal bleeding is just staggering.
It's usually the biggest shock for patients.
I bet. Let's look at continuous combined HRT for a second. So, this is the therapy typically given to postmenopausal women who still have a uterus, where you take estrogen and progesterone every single day.
Right.
And the stated medical goal of continuous HRT is to eventually stop having periods completely.
Yes, that's the aim.
Yet, the statistics show that 80% of women using it experience breakthrough bleeding or spotting in the very first month. 80%.
8 out of 10 women. It is by far the most common early side effect. And while it drops to 50% by month 3 and down to less than 10% after a year, it is highly disruptive.
I'm looking at these numbers and just thinking about the sheer frustration this must cause. You are prescribed a daily medication specifically to end your periods, and as a direct result, you end up spotting unpredictably for up to 6 months. I mean, how is that not just a fundamentally broken treatment protocol?
It looks entirely counterintuitive from the outside, I'll grant you that. But it makes perfect sense when you look at the architecture of the endometrium, which is the lining of the womb.
Okay, break that down for us.
Think of estrogen as a fertilizer. It commands the endometrial cells to multiply and thicken. Progesterone, on the other hand, is the gardener. It stops the growth and eventually triggers the tissue to shed.
Right.
So before you start HRT, your natural hormones have been fluctuating wildly for years. That means the lining of your womb is likely chaotic. Some patches are thick, some are thin, some are highly reactive.
So it's a completely uneven landscape.
Exactly. It's an uneven lawn. When you introduce continuous combined HRT, you are applying a steady daily dose of both the fertilizer and the gardener to that uneven lawn.
Oh, I see where this is going.
The ultimate goal of continuous HRT is to thin the entire endometrial lining out into a flat, stable, dormant state. But as the thicker, chaotic patches of tissue are starved of their natural hormonal spikes, they die off and slow away.
And that sloughing is the unpredictable breakthrough bleeding.
Precisely. It takes 4 to 6 months for that entire internal landscape to remodel itself, shed the old uneven layers, and become completely flat and stable. The messy transition is a required step to reach the dormant state.
That actually makes a lot of sense. And we should probably clarify from anyone listening who is still in perimenopause, meaning you're still having occasional natural periods, you would likely be prescribed sequential HRT, right? Not continuous.
Correct. With sequential, you take estrogen every day, but only add progesterone for roughly 2 weeks of the month.
Because in that scenario, you're deliberately mimicking a natural menstrual cycle. The progesterone drop triggers a predictable monthly withdrawal bleed.
Exactly. But even then, the first few cycles can be unusually heavy or erratic as your body's natural remaining hormones kind of clash with the new synthetic rhythm.
So the baseline expectation across the board is a 12-week acclimatization phase. But our sources are really clear that you shouldn't just passively suffer through it.
No, absolutely not.
Right, because to actively manage these side effects, you need to play detective. HRT isn't just one monolithic substance. It's a combination of distinct hormones doing very different jobs. You have to figure out which hormone is the actual culprit behind your specific symptom.
And segregating the side effects by hormone is the very first step in troubleshooting. When we look at estrogen, the excess symptoms typically manifest as nausea, leg cramps, the breast swelling we discussed earlier, and sometimes tension headaches.
Because estrogen is excitatory. It stimulates tissue.
Right, wakes things up.
But then we look at the progesterone side of the equation, and the profile is entirely different. The sources describe progesterone side effects as this heavy premenstrual feeling.
Yes.
We're talking about severe irritability, acne, lower abdominal bloating, and a significant drop in mood. In fact, the data notes that 1 in 20 women experience something called progesterone intolerance.
Which is a severe neurological reaction.
Neurological. How does that work?
Well, when your body processes progesterone, it breaks it down into a metabolite called allopregnanolone. This metabolite crosses the blood-brain barrier and binds to GABA receptors in your brain.
And GABA is the neurotransmitter that's generally supposed to inhibit brain activity and keep you calm, right?
Normally, yes. But in a subset of women, this sudden surge of hormone binding to their GABA receptors causes a paradoxical depressant effect.
The sources describe it as a literal dark cloud effect. I mean, many women taking micronized progesterone, which is the body-identical version, often sold under the brand name Utrogestan, they take it at night because of its sedative properties.
Because it does make you sleepy.
Right. But instead of just waking up rested, they wake up with a profound sensation of gloom or this heavy, depressive brain fog that hangs over the entire morning.
Which completely defeats the purpose if you sought out HRT specifically to cure the cognitive brain fog of menopause. You are essentially trading a hormone deprivation fog for a chemically induced depressive fog.
Yeah, that's incredibly frustrating. And this leads to the most obvious question, I think. If estrogen is the accelerator that brings back your energy and clears the hot flushes, and progesterone acts like the emotional brakes that causes the bloating and the dark cloud, why take the progesterone at all?
People ask this all the time.
I mean, why not just drop the hormone that makes you feel terrible and only take the estrogen?
Because that is a non-negotiable hard stop in reproductive medicine for anyone who still has a uterus.
Oh, okay, why?
If you take estrogen alone, the fertilizer is running constantly with no gardener to keep it in check. The endometrial cells receive a continuous chemical command to multiply.
Right, which we established is what estrogen does.
Exactly. And as they replicate endlessly, the lining thickens into a condition called endometrial hyperplasia. Now, every single time a cell divides, there is a microscopic chance of a genetic mutation.
Oh, I see.
So if you force those cells to divide rapidly and continuously without the protective stop signal of progesterone, those mutations compound, drastically increasing the risk of uterine cancer.
Wow, so the progesterone isn't there to make you feel good. It's there to act as a cellular failsafe against unregulated cell division.
It is entirely protective. The only individuals who can safely take estrogen-only HRT are those who have had a hysterectomy and physically no longer have an endometrium to protect.
Okay, that makes perfect sense. But if we are locked into taking both hormones, we need practical solutions for when the side effects don't vanish after month 3, because you aren't just stuck with the first box of pills your doctor hands you.
Not at all. Modern HRT is highly customizable.
Right. The sources emphasize that it's a process of trial and error involving route changes, formulation changes, and simple behavioral tweaks. Let's start with route changes.
Sure.
So if the oral pills are causing terrible nausea or fluid retention, the guidelines suggest switching to transdermal options. So that's patches, gels, or sprays that absorb directly through the skin.
And changing the route changes everything because it dictates how the liver gets involved. Yes. When you swallow an estrogen pill, it travels down your digestive tract and gets absorbed straight into the portal vein, which carries it directly to the liver. This is known as first-pass metabolism.
Okay. And what does the liver do with it?
The liver acts like a chemical security checkpoint. It recognizes this massive dose of oral estrogen and works aggressively to process it. In doing so, the liver is stimulated to churn out specific proteins and coagulation factors.
And let me guess, that causes the side effects.
Exactly. It is this intense liver processing that triggers the systemic nausea, the fluid retention, and the digestive bloating.
But when you stick a patch on your thigh or, rub a gel onto your arm, the estrogen bypasses the digestive system completely. It seeps through the dermal layers straight into the bloodstream.
It sneaks right past the liver's security guards.
I love that.
The liver eventually processes the hormones as they circulate, of course, but it doesn't experience that aggressive, concentrated first hit. Consequently, it doesn't dump those nausea-inducing proteins into your system.
Beyond changing how the hormone enters your body, you can also change what kind of hormone you are taking. Our sources highlight a major shift from synthetic hormones to bioidentical or body-identical hormones.
This is a huge shift in the field.
Yeah, it seems like the older synthetic progestins are often the culprits behind the severe mood drops and the acne. But switching to bioidentical hormones like dihydrogesterone or micronized progesterone has a profoundly better impact on mood.
And just to clarify, the term bioidentical means the hormone is manufactured, usually from plant sources like yams, to have the exact same three-dimensional molecular structure as the hormones your ovaries naturally produced.
So they match perfectly.
Exactly. Synthetics are close, but their shape is slightly different. And because the synthetic molecule isn't a perfect key for the body's locks, it tends to jam into other receptors,
Like what?
like testosterone receptors, which triggers off-target side effects like acne or unwanted hair growth. Bioidenticals fit the locks perfectly, drastically reducing those rogue side effects.
That's fascinating. And the clinical assessment for that Bijuve capsule also notes that body-identical progesterone has a neutral effect on your blood lipids.
Which is very important for heart health.
Right, because synthetics can actively mess with your lipid profile, meaning they can negatively impact your cholesterol levels, driving up the bad LDL and lowering the good HDL. Bioidenticals don't interfere with your cardiovascular plumbing in that way.
And if you're still experiencing minor issues even on bioidenticals, there are behavioral tweaks.
Yeah, the sources mention that if you do need to take oral pills, simply taking them at night with a meal allows you to sleep through the peak of the nausea.
A very simple, effective fix.
And for the breast tenderness, the Royal Osteoporosis Society even suggests a temporary low-fat, high-carbohydrate diet to help ease the tissue swelling.
The toolkit for managing these symptoms is incredibly robust. You just have to be willing to advocate for yourself and try different combinations.
But this raises a glaring logistical question for me. If transdermal patches completely bypass the liver, reducing nausea and bioidentical hormones match our receptors perfectly, reducing mood drops and protecting our cholesterol, why do doctors ever prescribe oral synthetic pills to begin with?
That's a fair question.
I mean, why isn't every single patient instantly put on patches and bioidenticals?
It comes down to the complex realities of individualized medicine and absorption. First, skin is a highly variable organ. Some women have dermal layers that simply do not absorb transdermal gels or patches efficiently.
Really? Like, it just doesn't sink in.
Exactly. They can wear a patch all week and barely register an increase in blood estrogen levels. For them, the oral route is the only reliable way to achieve symptom relief.
Okay, I hadn't thought of that.
Second, you have to consider age and the severity of the deficit. Younger women who enter premature menopause, often in their 30s or 40s, require significantly higher sustained dosages of hormones to protect their bone density and cardiovascular health until the natural age of menopause.
So gels might not be strong enough.
Right. Sometimes, specific oral combinations achieve those sustained high levels more effectively than gels.
There is also the reality of daily compliance, which the sources brought up. Managing HRT can be exhausting. Applying sticky gels that need time to dry, remembering to change patches twice a week, and taking a separate progesterone pill every night, it's a lot of homework.
It's a huge burden for a busy person.
Yeah. So for many patients, having a single capsule that contains both the estrogen and the progesterone, like Bijuve, is the only way they will consistently stick to the therapy. Because if a treatment is too complicated, it fails entirely.
Compliance is the hidden variable in all medical data. The absolute best medication is always the one the patient will actually take every day.
We have established that patience is vital and that tweaking the treatment is part of the process. But we have to draw a hard line on when patience becomes dangerous. If you're listening to this and tracking your symptoms, you need to know how to distinguish between an annoying biological adjustment and a medical emergency.
Yes. When do the red flags go up?
Let's talk about the timeline first. That's your first red flag regarding bleeding. We know irregular spotting is normal at first, but if that unscheduled bleeding persists continuously beyond 6 months,
Or if you have been completely settled and bleed-free for a year and suddenly start bleeding heavily again,
right, that requires an immediate doctor's visit.
that is when they order an ultrasound to measure the thickness of the endometrial lining. While sudden bleeding is often just a sign that your hormone dosage needs adjusting, you absolutely must rule out the endometrial hyperplasia or cancer we discussed earlier.
Then we have the acute emergencies. These are the symptoms where you don't wait for a GP appointment. You call emergency services immediately.
Very important to know these.
We are talking about pain, redness, or swelling in your calf, which points to a deep vein thrombosis, a blood clot in the leg. Sudden sharp chest pain and breathlessness, which are hallmark signs of a pulmonary embolism, where a clot travels to the lungs. Or sudden neurological symptoms like facial drooping, severe visual changes, or difficulty speaking, which indicate a stroke.
Now, we need to contextualize those severe risks because it sounds terrifying. The risk of blood clots and stroke is slightly elevated when taking oral HRT, and this loops right back to the liver's first-pass metabolism.
Right. the security checkpoint.
Exactly. When the liver aggressively processes oral estrogen, it produces extracoagulation factors, proteins that make your blood stickier and more prone to clotting.
But the transdermal options are different, right?
Yes. Extensive data shows that transdermal patches and gels, because they bypass that liver processing entirely, carry a neutral risk. They do not increase your baseline risk of forming a blood clot.
We also need to talk about breast changes. We detailed how diffuse breast tenderness is a standard temporary reaction as the tissues gorge on fluid. But persistent localized breast lumps or noticeable dimpling of the skin on the breast, those are not part of the downregulation process.
No, those require immediate oncological screening. The clinical distinction is diffuse discomfort versus localized structural changes.
Meaning, general achiness across the whole chest is an adjustment, but a hard, distinct mass in one area is a red flag.
Exactly.
But as someone navigating this, it is so easy to hear that list and just feel paralyzed. I mean, the body's adjustment phase causes headaches, but a severe headache can also be a stroke. It causes leg cramps, but leg pain can also be a blood clot. How do you live with that fear without spiraling into panic every time your body twinges?
It requires looking at the statistical reality versus the psychological fear. For women under the age of 60 starting HRT, these severe cardiovascular events are statistically exceptionally rare.
Like less than 1% rare.
The absolute risk increase is a fraction of a percent. The most practical way to navigate the fear is to evaluate the nature of the pain. The recalibration phase is characterized by a low-level, gradual hum of discomfort.
A hum. Okay.
A tension headache that builds over the afternoon is a hum. An emergency is a loud, sudden alarm. It is a thunderclap headache unlike any you have ever felt, accompanied by numbness. It is a sudden, searing pain in the calf that is hot to the touch. You are looking for sudden, severe, or entirely new symptoms.
So, if you are looking into HRT, here is the mission briefing. The initial side effects, the bleeding, the bloating, the breast tenderness, and the blues, are documented physical proof that your cells are recalibrating to a new chemical reality.
It means it's working.
Give your body the 12 weeks it needs to downregulate those receptors and thin out the chaotic endometrial lining. Track your daily symptoms to determine if the excitatory estrogen or the depressive progesterone is causing the friction. And most importantly, if the discomfort doesn't lift, demand adjustments.
Switch the pills for patches to bypass the liver or ask for bioidentical hormones to protect your mood.
You are the architect of your own treatment.
The data proves you do not have to accept suffering as the default state. The tools exist to fix it.
Before we close out this deep dive, there is one final piece of data from our sources that presents a fascinating mystery. The clinical evidence shows that starting HRT around the time of menopause, in your 50s, brings rapid cognitive improvements.
It physically protects the brain and clears the neurological fog.
Yet a paradox emerges in the data. Initiating HRT much later in life, specifically over the age of 65, appears to be linked to an increase in the risk of dementia.
It is a profound biological paradox. How is it that the exact same bioidentical molecules that act as a neuroprotective shield in our 50s somehow interact with our neural pathways completely differently decades later?
It's wild.
It suggests that the brain's physical receptors, or the fundamental way our neurons process hormones, fundamentally shift as we age past a certain threshold.
It is a stark reminder of how dynamic and ever-changing our internal chemistry really is. The cure at 50 becomes the risk at 70. It's something to mull over as you navigate your own hormonal recalibration. We will catch you on the next deep dive.